So the next part of the presentation is about the principles OTs and physios commonly use to guide their practice when working with individuals with dysphagia and positioning concerns. So these are the fundamental principles that we would apply to each individual. After much discussion between us, we have come down to 3 guiding principles that we would commonly use to apply to the individuals that we work with. So the first one is collaboration, collaboration, collaboration. We would only be involved with the individual for positioning for dysphagia management after a speech pathologist has engaged us. If a speech pathologist is not involved and we suspect swallowing difficulties, then we would need to refer to one. It is crucial to have the speech pathologist's swallowing assessment to determine the presence or absence of aspiration. This is essential in order to plan strategies that will support the client to have a safe and effective swallow. Implementing positioning strategies without this background information can be dangerous. What we would like during this collaboration is we would expect a joint visit with, if possible, with the speech pathologist and the OT and physio. We may also be working with equipment suppliers to explore positioning equipment options. We may need to trial various equipment. We would be working through strategies and positioning together to come up with the best outcome to meet the needs of the client. It takes a lot of compromise and discussion around what is possible and where the priorities are for that client. Generally, we are unable to achieve the perfect position to meet all the needs, hence the joint visit is important to be able to weigh up the pros and cons together. What is going to work in the real world? Regular communication between the team is vital to ensure the best possible outcomes for our client. Our second guiding principle for us is about applying seating principles. When OTs and physios consider positioning for mealtimes, many factors need to be considered. Whatever the equipment the individual may use or not use, the alignment of the pelvis is the foundation. If the pelvis is not supported, either by the individual's own body or with assistance by equipment, then our overall goal of safe positioning for mealtimes will be compromised. Once the pelvis is stable, then consideration also needs to be given to trunk positioning, foot position, upper limb posture, and head and neck alignment. An OT or physio may assess this by conducting a mat evaluation, particularly for those individuals who use wheelchairs. We need to observe mealtimes using the current positions and equipment. We need to talk with the carers, the individual, and you, the speech pathologist. Any intervention that we prescribe will be based on the following points. Is there postural symmetry? We want to promote and sustain skeletal alignment. We need to consider the postural support and maintenance. We want to prevent, correct or accommodate any skeletal deformities that we might see that has been caused by abnormal pull of muscles on the bones. How can we maximise head control? We want to align the vestibular system and maintain an even eye level to promote physical, cognitive and sensory function. We need comfort. We want to promote postural tolerance for comfort, for rest and to manage fatigue. The body needs to change position and posture throughout the day depending on activity. We want functional activity. We obviously want to facilitate any purposeful movement we can, or we want to control abnormal movement patterning. We also need to consider, on top of all this, any pressure issues or skin breakdowns the client might have. We need to consider pressure care management and skin breakdown whenever possible. Following on from that seating principles, it is also useful to note that historically a 90-90-90 sitting position was believed to be the optimal sitting posture. Do you know what I'm saying when I'm saying 90-90-90? Feet, so yeah, so hips, knees and your ankles, so 90-90-90. So historically that's been that's where we want to be, 90-90-90, but evidence is now emerging to challenge this belief as the 90-90-90 sitting position may not promote function, especially when the capacity to maintain such an erect posture is compromised by fatigue. Holding this erect position is energy sapping, and I can see already from looking at you today that you're sapped. So often, OTs and physios will use tilt and space or recline in the equipment they are prescribing to be able to assist the individual, not only to be comfortable, but to assist with the safe swallowing. It is vital that the speechy, the OT and the physio understand what these terms mean And I'm sure everybody knows what tilt and space and recline is and would be able to define it easily, but we'll just go over it as a refresher. So tilt and space, as you can see from this photo, is when the entire chair shifts its position on its frame as one unit while maintaining the angles of the hips, knees and ankles. So it's shifting, the whole chair is shifting back, so that all the back angle stays the same. The ankles at the ankle stays the same, the knee stays the same. It's just shifting back, so it's tilting everything in space. Other terminology that we use is recline, and this often gets confused with tilt and space, but recline is about the adjustment in the angle of the back of the chair, or, as the physios like to put it, increasing the hip angle. So that's when we're actually opening up that back angle to recline into position. So it's not all going together. Sometimes it can, but often it's just tilt and space is on its own and a recline is on its own. Yes, makes sense? You can all go back to your OTs and physios in your team and whiz them and impress them with your knowledge. Just to go on from that point about tilt and recline, OTs and physios often are talking about tilt and recline, and when we are talking about it, it is really important to be specific and clear. So you can see from this picture here, this man here, as a mealtime management plan may indicate a degree in tilt. You might have a degree, and a common, I think what needs to be decided when you're working out what recline and tilt is making sure that you have the same meaning. So what does a recline of 30 degrees mean? So if you look at this fellow in the top picture here, are we talking about a 30 degree from upright, or are we talking about 30 degree raise from horizontal? So it might be from, if you have a health background, if you're working in hospitals, you might be in a bed and you're actually saying, well, 30 degrees from horizontal, which is what this fellow is probably looking at. But what we generally do in practice is when you're seated, you're reclining back from being upright. So 30 degrees looks very different, doesn't it? So if you got that wrong, imagine this fellow being fed like that. So it's very important information that we get this across and we have some consistency, and that we do so with our parents, with our carers, with our group home staff, our day program staff. Whoever's involved in the positioning of the person needs to be able to accurately and consistently replicate a position. So we need to make sure that we all are on the same page. And as mentioned before, photos of correct positioning are the most accurate way of recording recommended positioning, obviously combined with demonstration and communication with all the parties. And our third guiding principle, wait for this, no one size fits all. I wish it did. I wish you could just say, oh yes, that person's a GMFCS 5, yes, we should just have this blah, 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 done. Unfortunately, that's not the way that we work. So it is acknowledged that optimal positioning is not always achievable. Each person's positioning will need to be individualised to ensure they can achieve their positioning goals. Various considerations such as the requirements of the person's support people, the person's lack of postural endurance and equipment limitations can all impact on the person's positioning. We've also got to consider that there's going to be varying presentations depending on the person's diagnosis, their age and their physical presentation. For example, they might have had retained reflexes, they might have high tone, they might have low tone, they may have had corrective surgery, or they might have a musculoskeletal deformity or a degenerative condition. We also need to consider the person's routine across the day and the person's level of independence, the equipment they have access to, the equipment they might be waiting for funding for, all have an impact on the things that we need to consider, and also we need to also have the carer's level of support. These will affect the clinical decision making and outcome of optimal position for feeding.
So as Tess previously mentioned, my area of expertise is physiotherapy. So from my discipline's perspective, I would be concerned with postural alignment, skeletal deformity, bone, joint, muscle action and interaction, muscle strength and endurance, and how these may be affected by a person's overall health, taking into account the presence of respiratory, cardiac, orthopaedic and neurological conditions. This would mean that we may observe the person's alignment in the context of different positions and consider how the person might maintain those positions. We may also consider how their posture affects their ability to aerate their lungs well, to cough effectively, and the effect their posture may have on their overall respiratory health. We all come from different frameworks and philosophies in our work, and that will affect our goals. These pictures highlight situations we have come across. They're not our clients, but they're reflective of things that happen when you're working, things you see when you're working in the real world. So if we can just have a look at these pictures and analyse them a little bit. So in the first photo, there's a child who is possibly being force-fed. The carer has an arm behind her head and is holding down her arm. Her trunk and head are rotated. She's not engaged with the carer, who is standing. There is no eye contact. In the second photo, a child is being fed again by a person who is above him. So his neck is extended and he is possibly in a stander. He has nowhere to rest his arms, and it appears that the food is being spooned to the side of the roof of his mouth. In the third photo, a child is being held to be fed. He has the potential to neck extend as the food is introduced. There is eye contact, but the person feeding him is again above his eye level. His legs and feet are suspended. And then in the last photo, the child is being tube fed, with the carer sitting to the side and not looking at the child. The child's neck is extended. She does not seem to be sitting with her pelvis and therefore her trunk symmetrically aligned. Possibly her feet are not supported. And in this position, if she has difficulty with managing her saliva, this may pose a risk. So what could be the consequences of this kind of working in this way? Well, in all of these photos, there's no active participation for the child. It's a carer task to complete. There does not appear to be any functional or positive social experience for the child. The problems are poor positioning of the child and the carer. In all of the photos, the child is not well supported. This can pose swallowing risks and increase their fatigue. It's important during feeding for the person to be as alert as possible, to reduce fatigue during feeding, and to assist the person to be able to remain in an optimum feeding position. These factors help to reduce the risk of feeding and swallowing difficulties. So how would we do this? We need to look at careful positioning and seating, postural alignment, supportive seating, and adaptations if necessary. Carer instruction and education on the importance of the person or child's positioning, and also on the positioning of the carer in relation to the child or the person that they are feeding. Okay. So here are some additional photos, again, things that we may have seen in our work lives. I have seen some of them, definitely. So here are just a few more examples. Person in a standing frame. The person looks perfectly happy, but is that a good position for her? Standing to eat may cause additional fatigue, as it will be difficult for her to hold the position for an extended period of time. She may have been standing already for about an hour or hour and a half, so she might be getting a little bit tired. She looks quite happy now, but in 10 minutes will she still look as happy, especially if she's using effort to feed? She may have to place increased pressure through her arms in order to maintain that upright position. Feeding will require concentration and hand-to-mouth coordination. The strapping and supports that are normally used for support in a standing frame may cause increased abdominal pressure, and this may increase the possibility of reflux. The table may not be at a suitable height for her to reach for her food and for her to move the arm easily from hand to mouth. It looks okay at the moment, but is that going to be right later? She may tend to lean forward to reach her meal or drink. This may compromise her stability in the frame, and the lateral supports may not be able to adjust with her movement, as this is not a dynamic stander. Is the use of a standing frame convenience in this situation? Maybe it's in a day program. In this context, the person would not be at the same level for socialisation if it's a meal time and others are seated at a table. Then we have the young boy sitting at the table, and he doesn't look all that comfortable. He seems to be struggling a little bit. The table may be too high. He has his head turned to eat. Why is this? He is stabilising with one hand and has reached with the other hand and he needs to rest his elbow on the table for his hand to reach his mouth. He's gripping the food with his index finger and his thumb, and his other fingers are curled. His upper body looks slightly rotated on the chair, so he's not really in a very comfortable position for an extended mealtime. In the third picture, it's a mother feeding her child on her lap. He's reclined, he does not look relaxed. The mother is trying to support his body and support his head and support his chin and give him a drink with a cut-out cup. This will be very tiring for the mother as well as for the child. There may be a risk for the child to fall into neck extension, and then this then poses a risk of choking and aspiration. So they were just to get you thinking about the things that you can see and may have seen. And now for the next part of the presentation, we're going to consider 3 clients during meal times and how we would apply the guiding principles using various strategies to provide adequate support. All right, so the first child, I received this referral for this little boy who is 7 years old, has Down syndrome. He has limited verbal communication and requires prompting for his meals. He's able to use a fork and spoon, so he may have sufficient hand function and eye-hand coordination to feed himself independently. He drinks mildly thick fluids and eats normal, finely chopped foods. However, the pacing of his feeding and eating during meal times is an issue. So what sort of questions might we ask about this referral? What would we be considering? As a physiotherapist, I would consider the referral information and also the following. He has Down syndrome. What are the specific things about Down syndrome that may affect his ability to concentrate and to maintain his position at mealtime and for that to be an enjoyable experience? Down syndrome may affect the size of the tongue, so he may have a large tongue. He may have a tongue thrust. He may also oral breathe. This may dominate his breathing pattern because his nasal passages may be narrowed and often are in the case of Down syndrome. This may affect his breathing and swallowing coordination. Consider that he may have low muscle tone. How long before the muscles of the swallowing muscles start to fatigue and risk increases? What does he do during mealtime? Does he eat quickly? Does he overfill his mouth? Does he tire and then require assistance with feeding? There's information on food consistencies that are managed by the child, but how well are they managed? Is he slow to eat, to chew, to swallow? How's the feeding paced? Is it self-paced, or does the carer assisting pace the feeding? How long will the mealtime normally be? Okay, we'll go to the next slide. So there may be other issues, and we need to consider these because children with Down syndrome often do have a lot of respiratory problems. They do tend to get a lot of colds, so they may have coughing, gagging, choking, recurrent colds, ear and chest infections, and these things may affect their ability to have an enjoyable mealtime experience. So how does he cope over the mealtime? He may be short of stature, so his arms and legs may be of a shorter length. So adaptation for seating and for bowls and feeding equipment may be required. He will need to have stable seating and feel stable in that position. He'll need to feel comfortable and supported and be able to move his arms and upper body for self-feeding. What is his vision like? Visual impairment would impact on the eye-hand coordination. And with Down syndrome, low muscle tone is usually present, and this may cause low endurance to exercise and activity, and the child will tire easily, particularly if there are cardiac issues. So he may fidget or move around because he's having difficulty maintaining his posture and eating. Therefore, it may be important to avoid a prolonged mealtime, as effort would be required for the activity of mealtime and maintaining the position. You also need to consider the context of the meal, the location and time of the meals, the length of the meal time. Is the seating suitable and comfortable? Are there issues of distractibility that may contribute to his moving or fidgeting? Is any mealtime better than any other? Is location and or time of day important? So we would also want to think about inviting other disciplines involved in the mealtime process, and so do joint visits, collaborate with the other disciplines involved. So ask the speech pathologist, the occupational therapist, about the approach required to address the mealtime issues. Okay, so there are more considerations, and we could go on and on. But there are many things that need to be considered, and in particular the child and his parents. So what is the parents' perspective? What are their concerns? Are they concerned about coughing or gagging? So do they have safety issues around this? What are their concerns around behaviour, tiredness, the length of the mealtime, the assistance for feeding? What's their goal? What's their goal for their child at mealtime? What is important for them as a family? Discuss these things with the parent, propose and trial strategies if required. If current positioning during mealtimes is not recommended and causing issues, would the parents be prepared to trial alternative equipment and positioning? If fatigue is an issue, address this, and it may be a combination of issues. As already discussed, this may be, for example, due in part to the context of the meal, the distractibility, the location, the time of the meals, the length of the mealtime, the comfort and suitability of the seating and equipment, and the presence of a low tone usually means endurance is lower. Ensure the child is well supported, well back in his chair, symmetrical and feet supported. Possibly discuss with the parents how to improve his endurance. What exercise or physical activity does he enjoy? Can this be adapted to help address his upper limb and postural fatigue and therefore improve his endurance at mealtimes? Finally, we need to look at his independence. So independence is important for the child and for the parents, probably, possibly. So how much independence do they want? Is he independent at the moment entirely with his feeding, or does he need assistance? Does he tire during the meal and then require assistance or refuse assistance? If he requires feeding assistance, the positioning of the person assisting is important. They should be positioned at eye level and directly in front of the child, not to the side, if at all possible. He may require adaptive equipment to help him feed. And we've already discussed the context of the meal. Consider the environment, the distractions. The environment may need to be set up to be supportive. They may need equipment. They may need to be located differently in a quieter and calmer environment and have a shorter mealtime. All of these factors, when considered, will help you to develop a clinical profile and an understanding of the possible intervention required. Consultation and collaboration with other disciplines and with the family and carers will help to develop strategies to target person and family-centred goals for this referral.